prolonged QT. We just focused on the QT rather than protoplasm, milieu, and what was the situation around this? Did I cause an issue in this patient's presentation that might have prolonged their QT? Again, a busy slide. Out of University of Arizona, you probably know about this website, but it gives us drugs that have risk of prolonged QT and torsade de pointe. And here we have, like, on this list, drugs that have been related to torsades. You know, quinidine, procanamide, haloperidol, like I mentioned. Interestingly, it mentions methadone. Okay, I found that interesting. So there's also other tables, drugs with possible risk of torsade. So these have evidence. Some of these are psych meds, you know, ziprasidone, olanzapine, and some are antibiotics. There's some evidence out there that these are prolonging QTs, and there's possible risk of torsades or a dysrhythmia. And again, that's what's clinically important. And interestingly, ondansetron, which I talked about in the initial case that this guy was given, is on that list. And thirdly, some drugs that have conditional risk. Again, and I mean, there's different degrees of how much QT prolongation might occur. So I think this is really a take-home slide and really the gist of my message today. And I like this slide because I think what it shows is what I'm trying to get across. If we are normal, let's say today, and we look at that cardiac action potential like I described earlier, we see the black line here. We see our phase 3 repolarization, okay? If we are a little abnormal, we have some genetic variant, and we have a long QT syndrome, now we become blue. Our QT is longer. This is slurred because I don't have a gene making that channel very well, and I can't get potassium out of the cell. Now, if I come into the emergency department, I'm malnourished, I'm sick, I have electrolyte abnormalities, hypocalcemia, hypomagnesemia, I'm hypokalemic. Now I become green. QT is even longer. And now if I'm in that ED and I give a patient a drug which maybe has shown to show just a little bit of QT prolongation, my gosh, now I prolong a little more. And as I mentioned earlier, the problem with that is my heart wants to depolarize while I'm repolarizing, and then I get what's called an early after depolarization. I get potentially a dysrhythmia. So that's really the take-home slide. And now I think I want to spend the next 15 minutes talking about methadone. And I love my job. I love the people I work with. I just feel so blessed to be where I'm at, both in my poison center setting and in the clinical setting. And we at Cook County Hospital, we love our patients. I mean, I learn so much from them every day. I had a lady about a week and a half ago. I always kind of grade who was my favorite patient of the night, and this lady was my favorite patient. She's got her suitcase, she's got all of her stuff, she's assuming she's going to be admitted, and she was going to be admitted. And she asked me, hey, can I take my methadone? Sure, let me see it. So she pulls out this bottle of methadone, and I said, yeah, go right ahead. So she pours it, you know, ever so gently in a little cup, just like this guy has. Hers was pink. And she starts drinking it, and she had like a sour look on her face, and I said, what's that stuff taste like? What did she do? She handed me the cup. So I tasted it. No, I didn't taste it. I'm like, how much is that? It's 80 milligrams. I'm like, oh, I don't even want 10 of that stuff. But it was just so cute that this lady's, you know, oh, go ahead, give it a try. But no thanks, I'm not gonna do that. But methadone is interesting. I heard in the pre-symposium that prescriptions for methadone are up 800%. I think Dr. Schaefer mentioned that. That is outrageous. How many here has had a methadone case through your poison center? All of our hands, people are on methadone. The most horrible cases are those kids who get in there, their grandma's methadone that's in the Snapple bottle in the refrigerator. They come in looking opioid. Maybe we save them, maybe we don't. I mean, a tragedy. But I think for methadone, I don't want to talk about its toxidrome. I want to talk about its cardiac effects and some of the literature surrounding the cardiac effects. And certainly, we hear about it, and we talk about folks in the press, folks from Hollywood. I mean, obviously, we know about Anna Nicole Smith's tragic death back in '07. But a year before that, when she gave birth, her son Daniel died. Now, both of them were taking methadone. Both of them were taking other drugs as well, antidepressants, sedative hypnotics. So if you look at their autopsies, that's what it's related to, overdose. But my question is, what were they suffering from PMS? Was there a protoplasmic issue? What was their QT's baseline? What was it after the methadone? I don't know. And you just wonder if there was some genetic link here between both of them and their deaths. How many people knew that methadone could prolong your QT? So a bunch of you, good. This was an interesting article. They actually sent out a survey to a bunch of docs from various specialties. These were internists, family docs, pain docs, and asked them about the ability of methadone and its effects on QTC. Can it prolong QTC? And less than half of them knew that the QT prolongation might occur with methadone use. I find that just fascinating. These are the docs prescribing it, okay? Then they asked them, does methadone potentially cause risk for torsades? And only about 24%, less than 25% of them even knew anything about this. So what I want to do is kind of look at the literature and see what does it say about methadone, QT prolongation, and potential for torsades or death. And really, this is a drug just like the other drugs I mentioned that might block that potassium efflux. And it does get metabolized, CYP3A4 and 2D6. So again, there's milieu issues. Am I seeing a patient in my clinical setting giving them a drug that might prevent them from metabolizing their methadone? Are you getting a call to your poison center and they're on another drug that's preventing their metabolism of methadone? Quite possibly. Interestingly, there's some chirality that's involved here. These stereoisomers, these non-superimposable mirror images, there's an S and an R methadone. And 2B6 metabolizes primarily the S methadone. And if I'm a genetic variant, I'm a slow metabolizer, I've got more of that around. You can see this gets very, very complicated. We just can't say drug and QT. There's lots of other concomitant issues that are going on here. So case reports, I found a couple dozen case reports, which I'm obviously not going to go through, but there was a common theme. QTCs were prolonged, they were on methadone, some of them had torsades, some of them died, and they related it to the methadone. So really, is there a link? Is there just an association? Is it causing the QT prolongation, the torsade, or the death? And that's really the question you're left with these cases. Some of them are very well written, some of them are not very well written. Most of these patients had, or a lot of these patients had electrolyte abnormalities. A lot of the cases didn't mention their electrolytes. A lot of the cases didn't mention other drugs that the patients were taking. Other cases mentioned other drugs that are playing a part. Some patients were HIV and on antiretrovirals. Some were on cocaine and drug abusers, which also can prolong that potassium efflux. So case reports are tough, but helpful many times. This was a meta-analysis, kind of a strange meta-analysis. They took a bunch of case reports and tried to find out, is there any credence to this? What's the degree of rise in QTC? They looked at 40 patients overall, and they found that the QTC was elevated, 598 plus minus 75 in a lot of these patients, and these patients were on whopping doses of methadone, ranged from 60 to 1,000 milligrams a day. That's a big dose. I haven't seen anyone on that kind of dose. Usually 60, 80, I'm thinking, man, you're on a hefty dose. 100, okay, but over that to me is a very high dose. I think the key from this meta-analysis for me, which I liked, is they mentioned the risk factors. There's other issues on top of methadone that's important, and they found that 85% of these patients with prolonged QTs had more than one risk factor. So again, it's protoplasm, it's milieu, and methadone and other situations. Let's look at some retrospective data. Okay, this is a look back at some data, 5 years of data, looked at 2 settings, looked at 17 patients, used methadone, average about 400 milligrams a day. So these folks are using a lot of methadone. It spanned between 96 to 2001. Again, big doses, large doses. Again, lots of confounding issues. 9 patients had other drugs that they were taking. 6 patients had potassium abnormalities. Who knows what their protoplasm was? Again, hard for me to take a lot home from this other than, man, those are some folks taking lots of methadone. But these data suggest, as they write, but do not prove that very high dose methadone can cause torsade de pointe, because they had patients who went into torsade. More retrospective information here. Their aim of this study was to evaluate the frequency of high QTs in methadone maintenance users at a tertiary care hospital. And what they wanted to basically do retrospectively is to compare drug users who were on methadone versus those who were not using methadone. Again, 5 years, hospitalized patients, and they looked at several features. And I think the kind of take home here is this graph, which looks at the different cases versus their QTC. So these folks are on similar doses of methadone, and what did it do to the QT? Well, you can see that the folks that are taking methadone, that's by the lighted box here, not the dark box, their QTs those were the only patients who had QTs greater than 500. 16% of them had QTs greater than 500. Whereas non-methadone users, none of them had QTs greater than 500. So does dose matter? Their lowest methadone dose with a QT greater than 500 was 30 milligrams a day. So it's really tough to hang your hat on dose causing prolonged QT. Again, retrospective data, not perfect data. They have another table here indicating the patients who had Torsades. These are the triangles, and you can see methadone dose on the x-axis. These patients weren't taking a lot of methadone, but my gosh, they had really long QTs, even went into Torsades. And here's folks out here with daily methadone doses that are ginormous, but not a large QT, not going into Torsades. So the take home is, does methadone dose really matter? It's again, food for thought. More retrospective data. This data is very biased. This is looking at voluntary reporting of adverse events with MedWatch. Okay? Between 1969 and 2002, they found over 5,500 adverse events associated with Torsades and QT respective to methadone. And interestingly, they reported more cases with Torsades than they did QTCs that were prolonged. And you would expect that. So you get someone with a prolonged QT, are you going to call in and report that every time? Probably not. Much more likely to call it in and report someone who went into a dysrhythmia. 29% were in the recommended dose range of methadone, and maintenance program between 60 to 100 milligrams per day. So interestingly, this retrospective study, I mentioned the long time span, 1969 to 2002, but actually over 90% of this data came from the last few years of that time span. So you wonder, are people just more up on methadone causing QT prolongation? Are we having more prescriptions written, which we know is occurring? Are we looking for it more often? So let's look at a cross-sectional study, QT prolongation in patients on long-term methadone maintenance. This study looked at 83 former heroin addicts on long-term therapy, and they had to be on methadone for at least 6 months. And they wanted to kind of look at incidence of abnormal QTCs, folks on single therapy methadone. And I drew a pink line here indicating 500, which I said is for me kind of concerning. And we only had 2 people that had QTCs greater than 500, and those weren't even the ones that had the highest doses. So it really, in this study, showed no correlation between QTC and dose, okay? They do go through lots of comments. We still should worry about this. We should get EKGs, measure their QTs, because they felt that was important. I've mentioned methadone doses a lot, but what about methadone concentrations? That's what this study did, this cross-sectional study. They added methadone concentration into the mix to see if the concentration relates to dose. They looked at 138 patients, ranging between 40 and 290 milligrams a day, and what did they find? Again, the bottom line here is they found no correlation between dose and QTC or level and QTC.